1919 was an auspicious year in history. The First World War ended, ushering a drastic change in the world order. The Philippine Islands had been a U.S. territory for 2 decades and was promised independence under the Jones Law of 1916. Progressive reformers saw the country and its people as a major target for modernization, and education was its main weapon. 7 forward-looking Filipinas came together in 1919 to create a school where young women could gain the knowledge and skills that would make them modern women. Paz Marquez Benitez was the first president of the Philippine Women's College. Jose Abad Santos was its first chairman of the Board of Trustees. Francisca Tirona Benitez was the second president, and with her husband Dean Conrado, guided the school from a house on A. Flores Street to its iconic Taft Avenue campus. In 1932, the college became a university, making PWU the first university for women in Asia founded by Asians. It provided a space where innovations in education flourished, and young people were encouraged to be the best that they could be. For over 100 years, the Philippine Women's University has been known as a leader in quality education. In 1934, PWU moved into its main campus on Taft Avenue, and since the 1970s has been co-educational. Located in the heart of Metro Manila, it is easily accessible by public transport and surrounded by affordable housing. Today's PWU offers undergraduate and graduate courses in several fields of study. Its business and management programs are responsive to the needs of industry, using evolving technology for global competence. PWU graduates excel in arts and sciences, education, social work, and diplomacy. Its fine arts and music programs have produced outstanding graduates through a holistic education that treasures heritage as well as excellence. PWU has pioneered in fields such as food science, nutrition and dietetics, medical technology, pharmacy, and nursing. PWU continues to play an essential role in producing graduates who possess the skills that make them competitive in the country and anywhere in the world.
Are a united community.
We may not be blood related,
but we Patriots are one big family.
Being part of the PWU community strengthens us.
Through the years, we support each other through good times and bad times.
We Patriots always have each other's back.
It's a big honor to be part of a community that is open to the ideas of each other.
It drives us to excel and be the best version of ourselves.
That's the standard of excellence that we Patriots strive for.
I'm thankful that this community lets us be who we want to be.
We thrive because we accept each other for who we are.
And like a family, we treat each other equally.
Actually, PWU gave us a home and helped us to be a patriot in society.
We may have different individual drums and instruments,
but we march to the same beat together as one united community.
Do you want to march with our community of patriots?
I am a patriot.
I am a patriot.
I am a patriot.
I am a patriot.
Good afternoon, everyone. Welcome for today's webinar entitled Optimizing Nursing Care Through the Use of Clinical Pathway and Proper Management of Abdominal Aortic Aneurysm Patients. My name is Adelson Navigitero, and I am your host for today's webinar. Distinguished guests, professors, students, classmates, ladies and gentlemen from all regions here in the Philippines, in China, and all over the world, once again, welcome to the School of Nursing webinar. We are in full pack this afternoon. We are also live simultaneously via YouTube and Facebook Live. Before we start, let me call on our classmate, Ms. Maria Cristina Rebollo, to state some of our webinar house rules and guidelines.
Hello, thank you, Sir Adelson. I am Maria Cristina Rebollo. Good afternoon, everybody. I'll be presenting to you our webinar house rules. Firstly, please ensure a stable internet connection once you have registered. To prevent background noise, all attendees will be placed on a mute mode throughout the sessions, with the exception of the resource speakers and coordinators. Third, type your questions in a Q&A box. Questions will be answered at the end of each speaker's discussion. Fourth, e-certificates will be issued only to the registered participants who will accomplish the post-webinar evaluation to be announced at the end of the webinar. Fifth, please use your registered full name and email address in answering the post-webinar evaluation. 6, kindly double-check your email address, as the organizers will not be responsible for any incorrect data submitted. 7, make sure to answer the evaluation form before leaving this webinar session. Evaluation link will be posted on the comment box and will be flashed on your screen along with the QR code. Failure to fill up the evaluation form will result in no e-certificate. 8, attendees' request for the evaluation form on PW official Facebook page and email after the webinar will not be entertained. 9, participants who will accomplish the post-webinar evaluation will be cross-validated using the officially registered participants. 10th, e-certificates will be emailed to the validated participant at least 1 week after the webinar. By joining this event, you have agreed to participate in a webinar that will also be live streamed in PWU social media platforms. Thank you very much and happy watching.
Thank you for that, Mr. Bolio. And now, let us put ourselves in the loving presence of the Lord as we start our event with an opening prayer to be followed by singing of the national anthem and the PWU hymn.
sa simoy at sa langit mong bukaw, may dilagang tulad, awit sa paglayang minamahal. Ang kisap ng watawat mo'y tagumpay na nagdidigdig. Ang bituin at araw niya kailan pa may di magdidinig. Lupa ng araw ng at ipagsintabay langit sa piling mo. Aming ligaya dapat may mga abi ang mamatay ng dahil sa'yo.
formally welcome us all, we would like to call on our class president, co-webinar facilitator, Ms. Maria Diana Santos.
Thank you and good afternoon, everyone. Your Excellency, Dean Minerva de Ala, Professor and Advisor, Dr. Agaton Manuel Alzate Jr., distinguished moderators and coordinators, speakers and participants, ladies and gentlemen, it is my pleasure to open this webinar entitled Optimizing Nursing Care Through the Use of Clinical Pathway and Proper Management of AAA Patients. And to welcome you to this event, let me take this opportunity as well to wish all of you, as well as your families, the very best for 2022. This webinar is therefore part of that effort too, and will contribute in a valuable way to work on these issues in medical surgical nursing. I thank all of you for being present, especially those of you in distant time zones. Your participation shows your continued strong commitment to the nursing community. Before introducing the interesting program for the webinar that will start today, let me first sketch some of the elements of the bigger picture. Clinical pathways are tools used to guide evidence-based healthcare. Usage of clinical pathways is a very relevant strategy in giving effective and ideal nursing care. It aims to translate clinical practice guideline recommendations into clinical processes of care within the unique culture and environment of a healthcare institution. Clinical pathways are also associated with improved patient outcomes and could play an important role in patient safety. Abdominal aortic aneurysm, or the AAA, is a life-threatening condition that requires a vast knowledge of a nurse. The endovascular approach for ruptured AAA has demonstrated superior results and survival compared to open repair if the anatomy is suitable, but the mortality rates remain high. The risk of surgery is not only influenced by the history of the patient and other factors of related, but also the skills of the nurse caring for that patient. Hence, one of the purposes of this webinar is to assist nurses in delivering the optimal evidence-based care for the patient undergoing endovascular AAA repair. Before concluding, I would like to convey my appreciation to the moderators and speakers for their time and support in contributing to this webinar, as well as my co-coordinators, Mr. Adelson Avigatero, Mrs. Shauna Hu, JC Makuha, Cristina Rebolio, Camille Rosales, and Jasu for the organization of this event in these challenging circumstances. These colleagues of mine did not deter even a bit from wanting to see our work prevail. I thank you all participants most warmly for your participation and wish all success in this webinar. Thank you for your attention, and I hope you'll learn from our topics prepared.
Thank you for the warm welcome remarks, Ms. Diana Santos. And now, we move on to the program proper. For our first speaker, he is a graduate of Trinity University of Asia St. Luke's College of Nursing in 2005. A graduate of Master of Arts in Nursing in Trinity University of Asia Graduate School by the year 2011. And Doctor in Nursing Management in the same school by the year 2017. He worked as a clinical instructor to the following schools: AME School of Nursing from 2006 to 2007, Far Eastern University Institute of Nursing from 2008 to 2009, and to Our Lady of Fatima University Antipolo Campus from 2009 to 2010. Trinity University of Asia Graduate School from 2017 up to present. He also became staff nurse 2 at Philippine Heart Center from 2010 to 2015, and promoted as a nurse 3 and assigned in coronary care unit from March 2015 to April 2016. Subsequently, on the same year, he became a clinical pathway coordinator until January 2018. On the same hospital, due to his diligence, he became a nurse 5 assigned as a manager in medical surgical unit from 2018 to 2021. In the same year, he became an officer in charge in medical surgical care 1 from March 2021 to July 2021. And currently, he is the Division Chief of Medical Surgical 1 from 2021 up to present. Aside from his clinical and educational background, He was also active in the different prestigious organizations in his chosen field. He is a member of Sigma Theta Tau International Honor Society of the United States of America from 2018 up to present. He is also a certified assessor of the Department of Health Nurse Certification Program. He is also a member of Society of Cardiovascular Nurse Practitioners of the Philippines from 2011 up to present. He is also a member and certified IV therapy preceptor of Association of Nursing Service Administration of the Philippines Incorporated from 2017 up to present. He is a former elected board of director of the Philippine Nurses Association Zone 3, Quezon City, Marikina chapter. He is a vice president of the St. Luke's Trinity College Alumni Association from 2018 up to present. He is the president of the Nursing Service Employees of the Philippine Heart Center from 2019 up to present. He was a fellow of the Royal Institute for Nurses in Singapore last 2018. He was also a certified hospital administrator, fellow in hospital administration, and member of board of examiners for oral examination for Philippine College of Hospital Administration. Aside from this, he was also fond of doing research as a principal investigator, co-author of numerous researches, both in hospital and in graduate school as an advisor. Due to his expertise, he was invited by numerous institutions as a resource speaker, and he is a regular lecturer for Philippine Heart Center in-house continuing education program, Philippine Nurses Association, and Association of Nursing Service Administrator of the Philippines, a distinguished nurse, educator, and author. To discuss clinical pathway, roadmap to effective nursing care, let me proudly introduce to you Dr. Joseph Peter B. Rigondola.
Okay, thank you, Sir Adelson, for that very kind introduction. Thank you so much. Again, thank you so much, Sir Adelson, for that very kind introduction. I would like to thank first Philippine Women's University Graduate School, a Master of Arts in Nursing under the supervision of Dr. Agaton Manuel Alzate for the invitation. Please allow me to share my screen. Thank you. Okay, can you see my screen?
Yes, sir.
Okay, thank you so much. Okay, so I will start. I'm tasked to talk about clinical pathway roadmap to effective patient care. So most of the time, every healthcare facility or organization is thinking in terms of strategies on how to actually deliver excellent quality care in terms of standardizing patient care efficiency, and of course, refocusing or putting patient on the center in terms of the whole journey of the hospitalization, basing on science-based or what we call evidence-based. So that's the utilization of the clinical pathway. So I think a lot of you just hear now in terms of this terminology. So in the succeeding lectures, slides, I'll be talking about clinical pathway. So this will be my outline of presentation. We'll start with the definition, the relevance, and what are the challenges in terms of the actual execution of the clinical pathway. And I'm going to share with you in terms of the standards on how we do things in terms of the implementation of the clinical pathway. And in terms of the actual execution or the implementation, there is a variability in terms of care. So what we call variances. We'll also talk about that later. Okay, so this is just a simple analogy of patient care and patient outcome. Along the way, there's a lot of challenges, but rest assured that at the end of the path, there is a standardized, optimized, efficient care in terms of addressing management for the patient in link with the clinical pathway. Okay, so what is clinical pathway? So again, allow me to read just for the definition: multidisciplinary proactive plan of care for specific diagnosis or procedure. Most of the time, we are dealing in terms of symptoms-based, for example, hypertension, hypotension, something like that. Procedural, most of the time, clinical pathway is based on procedural. Like for us, in being a cardiac center, we are dealing with coronary artery bypass graft and other open heart surgery or congenital heart disease. And of course, some diagnosis base. For example, acute coronary syndrome and alike procedures. It is a timeline of patient care activities which used by all disciplines in terms of planning, anticipating, implementing, and evaluating of care. So there's a timeline in terms of doing things for management for the patient. For example, day 1, day 2, day 3, day 4, and so on. In other institutions, other countries, they have this R-base specific on the type of procedure that we are dealing with. So this is considered a pre-printed order sheet and also serve as a document for the patient. When the patient discharged, this will be submitted to the medical records as part of the regular patient chart. Okay. If we're going to search clinical pathways in terms of literature, we will be dealing across in terms of clinical path terminologies, critical paths, care maps, other term, collaborative plan of care, the MAPS or the multidisciplinary action plan, the care paths, and anticipated recovery paths. So we're going to search its literature, going across with these terminologies. So one of the objectives of clinical pathway is to actually standardize patient care basing on evidence, best practices, current practices, best strategies in managing our patient, maximizing resources, of course, in terms of efficiency, minimizing delays, and of course, at the center, always the quality of patient care. You're also dealing with financial perspective in terms of decreasing the length of stay of the patient and in terms of hospital costs. Okay, clinical pathway are guidelines for patient care who have predictable course of illness, surgery, or event. Okay, later on we will expand more on that. Okay, there are typically based what we call the 3H, okay, high volume, high cost, or high risk diagnosis. For the high volume, we need to actually cater in terms of statistics, number of our patients admitted to your respective hospital or specific hospital. For example, for us in Philippine Heart Center, of course, we are dealing with ischemic heart disease, coronary artery disease in that statistic. So we are dealing with that same procedures and same diagnosis. So we need to actually help our Filipino people, our fellow men, in terms of addressing patient care and patient management in terms of that statistics admitted to your hospital or in our hospital. Of course, we are dealing with high costs. For example, coronary artery bypass graft costs a lot of money in terms of the entire procedure. So by dealing with that, we need to actually adapt with the utilization of clinical pathway. So there's a research will tell you that all patients enrolled with clinical pathway has this significant decrease in terms of the cost, in terms of the hospitalization. And of course, high-risk diagnosis. So we need to help in terms of managing that complicated high-risk diagnosis at the end in terms of a safe quality delivery of care. So these are the components of clinical pathway. If you're going to actually search the literature or the Google, no, in terms of clinical pathway, you will have this 4 components. So you have the timeline. For us, for example, the coronary artery bypass graft clinical pathway, we have 8 days pathway. For example, day 1, admission day, day 2, pre-operative, day 3, the actual operation, 3, 4, 5, immediate post-operative, with actually dealing with post-op at the ICU, 6, 7, 8, preparing for discharge. So in an 8 days timeline, the patient will be discharged for that open heart. Okay, so that's how we do things in terms of the timeline. Again, for other institutions, they have this hour base. For example, first 24 hours, these are the activities, something like that. Second, we have the activities or the interventions category of care. So later on, I'm going to share the format in terms of what we have in terms of the clinical pathway. For each timeline, we have this target outcome or objectives for the patient. So meaning to say, at the end of each day, we have this targeted outcome. For example, as simple as stable vital signs, hemodynamically stable parameters, absence of bleeding, absence of pre-op, something like that. So it depends in terms of the outcome criteria. But then again, at the end of each timeline for the clinical pathway, you have there the target objectives. Okay. So meaning to say, if the targeted outcome is not met, there's something wrong in terms of the current status of the patient. And then, of course, during the course of the hospitalization, they will come wherein there's a variability in terms of the patient care. So regardless if it's predictable, we have the standardized care, still there's a possibility or risk that our patient in terms of the journey or hospitalization may encounter variability or variance in terms of patient care. So we need to document that. We need to identify that for immediate action and later on for analysis for the improvement for the entire organization. So again, just a reiteration, these are the how we base in terms of the clinical pathway: high risk diagnosis, high cost diagnosis, and high volume diagnosis in link with the development of the clinical pathways. So again, clinical pathway can either be symptoms based. We have simple pathway in terms of chest pain, hypertension, or any related symptoms that is usually encountered in the clinical area that will actually guides the healthcare provider in terms of managing the same diagnosis. Another, we have diagnosis base. So for us, being a cardiac center, of course, we cater acute coronary syndrome, for example, in the ER, heart failure, coronary artery disease, congenital heart disease, therapeutic hypothermia for the ICU, and other diagnoses that we encounter in terms of the clinical area. And most of the time, very common, popular nowadays, procedural. So what are the usual procedures that your hospital is actually catering? So again, the basis here is that what are the usual admitting and discharge diagnosis in terms of statistics, in terms of your hospital data, so that you can actually base that in terms of the development of your clinical pathway. That will benefit, of course, the institution. For example, in Philippine Heart Center, we have this open heart surgery, congenital heart disease, the tetralogy of Fallot repair, ventricular septal defect repair. And for example, in other institutions like for example, ISAP, they have this trauma, something like that. And KTI, they have this transplant, It's based on specific per institution. Okay. So why do we need to actually utilize this methodology? I'm talking here about clinical pathway. So again, this is a coordinative. It encourages collaboration among different members of the team. This is standardized. This is organized. This is efficient. This is cost-effective. Okay, it served as a peripheral brain, in terms of for getting orders for the management of the patient. Of course, there's a lot of research will tell you that all patient enrolled in clinical pathway will geared towards high-quality patient care, which is a reflection of evidence-based and current practice. Improved documentation, of course. Alert healthcare team when expected outcomes are not met. This is what I'm talking a while ago for every timeline, the end of the day, the end of the shift, there's a targeted outcomes. Reducing the length of stay for our patient, improving patient outcomes, of course, encourage collaboration, and of course, in terms of financial perspective, reducing the cost of the hospitalization. So we have this research comparing the typical management for the diagnosis or procedure versus the patient enrolled with the clinical pathway, and there's a significant difference in terms of the cost, in terms of hospitalization. And how our clinical pathway used. So this is serve as the permanent chart of the patient. No, this is used in lieu of the standard decision order sheet. So it's considered decision order. So you just need to activate. No, care delivered and pathway outcomes are managed against the pathway and followed specific timeline, time frame. No, and activities outlined in the pathway are based in terms of the clinical practice guidelines, yung tinatawag nating CPGs, best practices, current practices, practice protocols, and other science-based, no, in terms of the interventions. So you may wonder, Doc, how do we develop clinical pathways? Of course, you need to have you need to have a baseline data in terms of what the hospital is actually admitting and discharging, in terms of the actual patient catering in your respective hospital. So we need to identify that. What are the usual admitted patients in terms of diagnosis? And of course, the final diagnosis in terms of discharge. So you will be basing on that data so that you will have a glimpse in terms of the usual patients you have in your respective hospital. Of course, after that, you need to have the group, no, in terms for us, we have this hospital committee on clinical pathways, multidisciplinary. I would like to highlight the role of the nurse. So the nurse is included on that committee, has a crucial role in terms of the development of the clinical pathway, in terms of the actions, interventions, no, ng mga nurses. Multidisciplinary pathway team is formed. Of course, we need to scan latest practice guidelines, protocol, literature, best practices, current practices for that specific topic, or can you say procedure or diagnosis. And then, of course, pathway is dropped. So don't worry about this because there's a lot of templated pathway, no, in terms of the soft copy. All you have to do is to actually fill out necessary interventions or necessary information for that template. Okay, and then after that, you need to have pilot testing. For example, if we have acute coronary syndrome, STEMI and STEMI clinical pathway, we need to actually pilot that sa ER, emergency room. And for a month, we need to have the observation, the comments and suggestions of the end user, which is the ER nurses and the ER fellows, particularly for that specific pathway. And then we will incorporate all of the comments and suggestions for the finalization in terms of the pathway. And then, of course, after that, ilo-launch natin. We will have a hospital-wide launching of the pathway so that all of the stakeholders will know we have this new pathway. We will speak the same language in terms of the cascading of information for that specific pathway. And then, of course, the very challenging part here is that the monitoring part in terms of the implementation and the variance. And of course, we need to actually consider pathway as developmental. So improvement in terms of the content interventions is always open, no, in terms of the end user for the specific pathway. Okay. So these are the challenges in terms of the clinical pathway. As a pathway coordinator before, I encounter a lot of this in terms of challenges. No, number one is difficulty in determining what a variance is. So there should be a clear definition of what is variance among the team, cascaded among the team, so that we will have the same definition and language in terms of the variance. Another is in terms of reporting. So we need to identify, we need to document and to report variances for improvement purposes. Because we cannot improve on something without data, not documented. So we need to actually identify that, encourage identification and documentation in terms of the variance. Additional support in terms of the staffing purposes, ensure hospital-wide coverage of variance monitoring. The inclusion of the technological advancement or technical support in terms of data management, especially for analysis. And of course, this is a continuous additional training among staff for the clinical pathway, latest development of clinical pathway, and of course, the variances. And this is very controversial, clinical judgment versus the standard of care. So again, clinical pathway is just a guide. What matters most is your actual assessment for your patient in terms of your clinical judgment and your clinical decision for the doctors is concerned, no, in terms of their management for the patients, and also for us nurses. In addition, the acceptance of the institution to the clinical pathway. So we need to have the support of the top management to be able for the entire organization to embrace, no, in terms of the clinical pathway. Training, of course, education, it's very important. Technicalities of the clinical pathway, of course, the adherence and the compliance of the medical staff in terms of the actual implementation of the clinical pathway. So these are the sample of the clinical pathway that we have in Philippine Heart Center. Later on, we will expound more on this. I have here simple illustration, putting all together in terms of the clinical pathway. So again, clinical pathway is evidence-based practice. It actually standardized care, no, follows clinical workflow based on best practices and clinical guidelines. And among the top objectives of clinical pathway is improve patient outcomes, being the patient at the center for the healthcare industry, and of course collaboration and reducing the cost in terms of financial. Patient safety, number one, and of course reducing the length of stay. And of course, there's a lot of challenges in terms of implementation of clinical pathway, and this is considered developmental. So we need to actually revise later on in terms of the actual standards that is actually changing over time. So this is one of the sample I have from other country in terms of the clinical pathway, acute coronary syndrome. Okay. So I have here what we have in terms of the clinical pathway from Philippine Heart Center. Again, for educational purposes, I'm showing you this. For the adult, we have symptoms-based acute coronary syndrome. For the ER, no, for the emergency room, you can encounter this. ACS, early ER discharge, initial assessment, STEMI and STEMI, acute coronary syndrome with primary percutaneous coronary intervention, mga angioplasty. We have here acute deep vein thrombosis, heart failure, limb ischemia. Of course, procedural, we have here bypass, single valve replacement surgery, mga valve surgery, of course. Therapeutic hypothermia for the ICU patients. For the pediatric, we have acute aortic dissection, ASD closure, congenital heart disease in terms of the tetralogy of Fallot, correction, BSD, Kawasaki disease, PDA, RHD. What we have, the latest now is the clinical pathway for COVID. This is just a guide in terms of managing COVID patient. Okay, in terms. So we have here, when it is developed, when it's approved, the actual final approved date, and of course the pilot testing, and of course the launching. And then of course, after the launching, we have the actual implementation in the clinical area. Okay. So I'm going to share how we do things in terms of the clinical pathway. So again, this is for the Philippine Heart Center in terms of the standards. Again, we have different standards or protocols or SOPs in terms of dealing with the clinical pathway per institution. So as usual, we have this demographic data of the patient. This is the usual patient chart, as you can see on the screen. So for the nurse to be able to carry out the pathway, you need to activate the pathway day by day, activated by the doctors. No? And actually should be activated by the doctor early morning for the start of the timeline for that specific day. So if there is no activation of pathway, that should not be carried out for the nurses, okay? And of course, the doctor should be reminded to activate the form. When we have tabletop discussion in terms of evaluation for the clinical pathway, the chief fellow in terms of the doctor's representative is always there. So we always remind in terms of the importance of activation and addressing this issue. No? And of course, we have this bullet interventions, no, mga bulleted orders. This is mandatory. Automatically, the nurses will actually carry it out and do this. Okay, so this is according based on the evidence-based latest interventions in terms of managing that patient. As you can see on the screen, for example, physician's order, bulleted order for the monitoring of vital signs. So you need to monitor that every 15 minutes and so on, etc. So all mandatory orders should be carried out unless deferred by the physician. So again, clinical pathway is flexible. Again, basing on your actual current assessment as a practitioner, you can do that. Orders should be checked and lined with red ball pen in terms of how we do things in terms of carrying out orders. Something like this. Okay. So we have here optional orders, or the small box, or the tick optional order. So again, we are laying down here intervention, for example, for the BTE, and then it's up to for the practitioner or for the doctor to actually tick or check what he or she wanted to be ordered in terms of addressing specific orders. For instance, for the diet, nutrition, low salt, low fat, diabetic diet is ordered, as you can see on the screen. So this is optional. The practitioner or the doctor just need to check specific for that diagnosis or procedure. Optional boxes or others not filled up should be highlighted after the form is activation. So para hindi na siya magawa or machikan. So this is how we do things in terms of the standards for the clinical pathway implementation. So these are the misconception and truth about clinical pathway. So sabi, pathways are cookbook orders, very complex and rigid, no? However, pathways can be individualized, standardized, organized, efficient, no? To suit patient needs. Pathways takes away practitioners' clinical judgment. Well, in fact, pathways are just a guide developed based on evidence, clinical practice guidelines, and serve as a guide only, peripheral brain, no? It's up to the practitioner or the doctor in terms of his or her actual current clinical assessment for the patient. If you think the patient's condition is not aligned with the pathway, then you can go out of the pathway. So we have terminologies, what we call out of pathway. Okay, basing on the clinical picture of the patient vis-a-vis with the pathway, outline of care, something like that. No? Using pathway is a waste of time because they are too long. Actually, it actually saves time in terms of efficiency, maximizing resources, no? Because orders are already pre-written, standardized, follows a workflow, serve as a reminder, and help avoid missing or forgetting orders. Kumbaga, nandun na siya lahat, all in. Pathways are difficult to use. Well, in fact, pathways are easy and convenient to use if you know how to use it. So it also included in the orientation of the newly hired nurses, including supplemental lecture for the nurses on the floor, no, in terms of how we do or execute clinical pathways once you have this. So these are the actual part of the pathway, you know, what we have in Philippine Heart Center. For instance, you have this inclusion and exclusion criteria. For that specific population, we need to have that specific inclusion criteria. Like for same understanding or same relationship in terms of the research, in terms of the respondents, no, we have that specific inclusion criteria, primarily for this procedure. Okay, and then we have this patient's data. Okay, and on the left side, you have your assessment notes. So tick box na yan, no? All you have to do is to tick box for the physician. Of course, we have this part also for the nurses as one of the crucial role of nurses in terms of the pathway. And then at the middle, you have this order or the activities or the care of plan for the patient. We have that bulleted intervention, which is mandatory. For instance, you need to have baseline parameters for your patients admitted for coronary artery bypass graft, mga bleeding parameters, electrolytes, and other related laboratories. And of course, you have this tick boxes or optional orders interventions. So we give choices for the practitioner in terms of interventions or activities for that specific patient. For example, if you want to actually repeat to the echo, something like that, you can have that. And of course, you have this pathway activation. Again, we need to have activation prior to the actual execution of the pathway, and of course, pathway acknowledgement by the nurse in charge. So again, during the course of the hospitalization, regardless whether it is standardized, efficient, evidence-based, there will come a time that the patient journey in terms of hospitalization will actually contribute for the variability in terms of care. Or can we say during the course of the hospitalization, variability can actually pose a threat or risk for the journey of the patient. So variance comes in. So variance can be positive or negative. For example, it is positive, for example, we have day 8 or 8 days for the bypass, and then the patient discharged on day 7. So that's actually positive variance. So that meaning to say the outcome of the patient is very good enough in terms of the entire procedure. So we have this negative variance. So we need to understand, identify, and document these variances so that it will serve as a quality improvement purposes documentation for us to improve for that specific areas. For example, if we are expecting patients to be extubated post-op less than 24 hours and the actual status of the patient is prolonged intubation, then that is considered negative variance. And we need to identify what caused that variance. We need to identify the clinical picture in terms of the patient. Okay. So what are the definition? Allow me to read. Any mandatory, we're talking here about the bulleted part of the intervention and the optional intervention that was not done. So we need to look into that. Any abnormal finding, any deviation from normal, any unmet outcome within the time frame, like what I've said a while ago, for each timeline, there is a targeted objectives or outcome. Meaning to say, if you did not met that outcome, there is a something happening in the patient's condition or in terms of clinical picture. Or outcome met earlier than expected. So for example, day 7 versus day 8, patient was discharged earlier. So that's considered outcome met earlier and considered positive variance. Okay. So in other definition or perspective, it is an action if something was performed was not intended to be performed. So meaning to say, with all of the outline care or intervention included in the pathway, it was not intended to be performed or was not done, something like that. Or something that was performed at the wrong time. So we need to have that specific timeline for specific intervention. Something that was not performed but should have been performed. Hindi nagawa, something like that. An outcome is a variance if a result of an action is different from expected. So in terms of variance analysis, we need to have a picture of the standards of care versus what is actually happening on the patient real time. Okay, so that's how we do in terms of the variance analysis. So in terms of variance monitoring, it will serve as a powerful clinical audit tool in terms of quality improvement. So we need to actually improve in terms of patient care, patient outcome, enables delivery of safe quality care, improves and enhances patient care processes and its delivery. And of course, it will serve as evaluation and again, developmental in terms of revising clinical pathway. And in terms of financial perspective, it will help reduce the cost of the hospitalization. So who can document variance? Of course, anyone, a member of the healthcare team who actually observe real time the actual scenario or patient variance given to the patient or see on the patient. So we have this variance code, standardized variance code. Later on, I'm going to share that for us to have easier analysis in terms of the data. And then variance notes may be written on progress or nursing notes and documented in the variance monitoring form. So this is what I'm talking about in terms of variance code. Because if we don't have the standardized categorization in terms of the variance, we will have a hard time, difficult time in terms of data analysis. So these are the standardized variance code in terms of the variance. For instance, Variance code A pertains to patient and family perspective. So if you're going to look into the indicators for the variance code, you need to have the cause of the variance pertains to patient medical condition most of the time, patient family decision, patient family availability, non-compliance to treatment, fund issue, and other reasons. So that pertains to variance code A. All of the reasons pertaining to patient family will fall on the variance code A. Again, we need to look as healthcare provider in terms of the factors, healthcare provider in terms of the variance code B. So for instance, you need to have medical order, provider's decision, provider response, or other reason. So if the reason of the variance is pertaining to the healthcare provider perspective or factors, so that's considered variance code B. For instance, medical order. For example, we are expecting for the bypass, for example, day 6, 7 trans out to regular room. However, the patient stay longer in the ICU. So that's considered the decision of the team in terms of the actual clinical condition of the patients. That's considered a variance code B, and also considered patient's medical condition variance code A. So after exploring the patient family concern, healthcare provider, we need to explore the system and the protocol in terms of the organization. So we need to look into the institution system. So you need to have, for example, results data availability, delay in test results, delay in procedure, cancellation of procedure, delay in patient transfer, supplies or equipment related issue, appointment availability, and other reason, exploring the system of the institution. So that pertains to variance code C. And of course, after exploring the patient family, the healthcare provider, and the system that we have in terms of the institution or organization, we need to look outside the institution. So if there is a problem in terms of transportation availability, home care discharge, so that is considered variance code D. So that's how we actually identify variances and for easier analysis later on for the reports. So these are some of the variance monitoring tool that we actually utilize to actually document variance. So I have here simple illustration putting all together in terms of the variance monitoring. Okay, so on the other side, you have this anticipated, standardized, budgeted plan of care. So I have this itemized plan of care for that standardized clinical pathway. And what actually happens current, real time to the patient. So that is the actual patient care that occur during hospitalization, the actual hospitalization or the actual hospital bill, and of course, deviation from the standards in terms of practice. So that's how we do in terms of the variance analysis. We need to explore, to look into the patterns, the frequency, and the trends of that variances for us to be able to have improvement, outcome, safety, satisfaction. Of course, very important, aside from patient safety, of course, to run the organization, reducing the cost in terms of the hospitalization. So these are some of the sample of the variance monitoring tool. Okay. So I would like to share our data in terms of what we actually observed and documented for the variance for that period, both for adult and pediatrics clinical pathway for the procedural pathway. So these are the leading types of variances. Extended hospital stay. For example, if bypass has this 8 days, we have this extended hospital stay of the patient more than 8 days, something like that. Extended ICU stay, if the care outline in the pathway will tell you that the patient will stay on the ICU for 2 to 3 days and the patient actually extended beyond that timeline, so that's considered extended ICU stay. And of course, mortality. There's a very small statistics, no, in terms of the mortality. But then again, we need to look into that. And of course, cancellation of procedure. So these are the leading types of variances. Exploring on these types of variances, what are the reasons both for adult and pediatrics in terms of extended hospital stay, extended ICU stay, in terms of mortality and cancellation. So these are the leading causes of that identified variances, mostly clinical, mostly pulmonary, pneumonia, pulmonary congestion, electrolyte imbalance, pneumothorax. So what actually happens real time to the patient in terms of the clinical condition during the course of the hospitalization for this patient. Okay, so again, it will not end on the identification of the variants. We need to have immediate action. We need to have a tabletop discussion and corrective actions to be able to improve on this area. So we need to have solution and concrete actions for this area. No? So we were able to actually address all of these scenarios during the identification of these variances. So it will not end on documentation alone. So as a committee, we need to have a concrete solution, again, for the end goal of patient outcomes, safety, and of course, quality, excellent patient care. Okay. Okay, to actually summarize, no, clinical pathway are guidelines that must be flexible enough to individualize depending on patient needs and responses. Again, what matters most here is your clinical assessment, current clinical assessment, current clinical judgment. It will never replace in terms of the clinical pathway guidelines. Clinical pathway is just a guide. Okay, care or intervention outlined in the pathway can be altered, must be altered if it's not clinically appropriate for the patient. Okay, if you need to actually get out of the pathway, you can do that. Depends on the actual clinical assessment, clinical judgment as a practitioner for your patient. Okay. Okay, so with that, thank you very much. That ends my lecture for the clinical pathway. So I hope you learned something from my lecture po. Thank you so much po.
Thank you, Dr. Rigondola, for that knowledgeable lecture. Okay, we will proceed now for our Q&A portion. For the next part of this webinar, we will proceed to an open forum, the most engaging portion of this webinar. This is to give our attendees the opportunity to find out more about the topic. So guys, if you have question for Dr. Rigondola, so you may now input your question to the chat box. Anything from the group? Okay, sir. We have our first question, and it came from one of our institution from San Lazaro Hospital. They're asking, are clinical pathways vary per hospital or institution? Not all diseases have clinical pathways, so how are they being classified? Is it by number of cases in the hospital?
Okay, thank you, sir, for that question. So that's very interesting question. So again, I agree, no, that is per institution in terms of your identification or in terms of the development of clinical pathway. So you need to look into your hospital data. What are the usual admitted patients to your respective institution? Of course, we have different set of patients. For example, us specialized cardiac center, we cater more on cardiac patients. San Lazaro, infectious disease, East Avenue, trauma, NKTI, NEPRO, something like that. So you need to base your data, no? Basing on your data so that you will have actually what will benefit in terms of the development of clinical pathway para mag-benefit ang institution real time, no? Kasi kung gagawa tayo, if we're going to develop clinical pathway na hindi naman madalas ma-admit, So it doesn't make sense, no? Something like that. So again, that varies per institution regarding or depending on your specific admitted patients, type of procedures that you actually do in your respective institution. So, for example, the coronary artery bypass graft pathway cannot be applicable to other institutions because, for instance, if you cater clinical pathway, if you cater open heart surgery, then you can actually benchmark the clinical pathway we have in terms of open heart. So something like that. No? So it depends on your facility and type of patients admitted and the procedures that you actually do most of the time.
Thank you, sir, for your answer. And we will proceed with our second question. And it will came from Dr. Agaton Alzate. Doc, you can now address your question.
Hi, Doc. Congratulations for
Good afternoon po.
Yeah, very good lecture. It's a very good lecture to enlighten everyone regarding the use of clinical pathway.
Thank you, Doctor.
I just want to make a good remark that clinical pathway can enlighten the work of both the doctors and the nurses, not only both the members of the medical team. But my question is there a separate clinical pathway for each department in a general hospital?
Actually,
another question is,
yes,
Doc, another question is, do you have a clinical pathway on the outpatient department or specific areas also like operating room? Because I'm a surgeon, and when I was listening to your lecture, my worry here, if I'm going to develop a clinical pathway here, is one, it is very hard to standardize practices of doctors, especially in surgery and in the medical area. So how did you do it?
Yes, po. Thank you, Dr. Agaton, for that question. No? What we did in Philippine Heart Center actually, when we formed the group for the committee for that specific clinical pathway, for instance, coronary artery bypass graft, multidisciplinary po ito, Doc, including the surgeon, the ANES, cardiologists, intensivists, critical care nurses, no, included, of course, the clinical pathway coordinator, kasama rin po dyan. So dapat magkasundo po in terms of the intervention. So we will create a standardized clinical pathway na mag-a-agree po lahat. Parang basing on CPGs, mga ganyan, current practice. Like for instance, Doc, sa bypass kasi yung mga surgeon natin, no? Mga thoracic surgeon, talagang may mga standards sila in terms of the outcomes, may mga ganyan, yung bypass time, may mga ganyan. No? So in-include lahat yun. No? May mga ganun po. And then, i-share ko lang po, one of the goal or the mission of the Philippine Heart Center is to actually create regional heart centers. So nagkakaroon po kami ng mga lectures in other regional heart centers na general hospital din po, na nagkakaroon sila ng clinical pathway, for instance, as simple as appendectomy, may mga ganyan po sila. Mga OB cases, no? May mga napuntahan po kami ganun, nag-create sila mga ganyang case per discipline, no? Per specific procedure or diagnosis. So may mga ganun po tayo, Doc. Outpatient, meron pong na-develop kami before pero parang workflow outline lang siya.
Workflow.
Parang ganun po siya, Doctor. Pero possible naman din po na magkaroon ng clinical pathway for the common reason for the patient going to the outpatients in terms of the data. May mga ganun naman po. So rest assured po, this is a collaborative in nature, putting all together the expertise of the different, can we say, expert, no? Surgeon, especially po, yung lahat ng practices natin vis-a-vis with the standards ng mga clinical practice guidelines, mga ganyan po. Putting all together.
because I observed that the clinical pathway is very useful to specialty hospitals. The specialty hospitals, because of the purposes that you have shown, lessen the stay, lessen the cost, everything. My worry is in government, general hospitals, and other medical centers. If I'm going to, let's say, motivate my students working in, mostly they are outside of the specialty hospitals, that will be again a problem on them, especially. I'm about to tell them probably after this session that they have to develop such paper, a thesis for that, a clinical pathway to become the first one to do it in the hospital where they're working now.
Yes, po.
Okay, that's all. Thank you very much.
Thank you, Dr. Agato. Nice meeting you po.
Nice meeting you too.
Thank you, Dr. Joseph D. Rigondola and Dr. Agaton Alzate. And now, let's proceed for the awarding of e-certificate for Mr. Rigondola. This certificate of appreciation is hereby granted to Dr. Joseph Peter B. Rigondola for sharing his outstanding knowledge and valuable expertise in the webinar entitled Optimizing Nursing Care through the Use of Clinical Pathway and Proper Management of AAA Patient, given this 10th day of June 2022 in the Philippine Women's University, Manila, Philippines, via Zoom and Facebook Live. Signed by Ms. Liana Santos, our event chairperson, Dr. Agaton Manuel Gerald Alzate, our course advisor, and our beloved Dr. Minerva de Ala, Dean of College of Nursing.
Thank you very much po. More power, Philippine Women's, and congratulations for the organizing committee. Thank you, Dr. Agaton. Thank you po.
Thank you, Doc.
Much.
Soon I will be inviting you to be a speaker here in Terda.
Thank you so much po. Thank you, Doctor.
Yeah.
To move on to the next part of our program, it's my honor to introduce to you our second speaker, an alumna of Jilin University in 2008, and also she got her Master's of Arts in Nursing from the same university in 2011. For 11 years, she served as staff nurse and currently works as the Chief Superintendent Nurse for the Vascular Surgery Department in Taijin Medical University General Hospital in China. Without further ado, to present the nursing management of endovascular repair of abdominal aortic aneurysm, let me welcome Ms. Ji Sen.
Good afternoon, Madam.
Okay, today I'll talk about the nursing management of endovascular repair of abdominal aortic aneurysm. So when it's come to EVAR, what is it really? EVAR means endovascular aneurysm repair. It's like you start out with a bad hair and you have two options. Option one, open replacement. You have a bad hair, you get some sweet paralysis, take it off, get a new one. Option number two, endovascular. You start out with this, open the box and roll it, blow it up, and then realign it on the inside. You're not really fixing the aneurysm. Say you are realigning it so that it's still a reasonable blood vessel. Today I'll talk about the perioperative care of AAA. Introduction. Let's look at the arteries anatomy. Aorta is the major blood vessel in the body that carries blood from the heart to the other organs. Abdominal aortic anatomy. And the aorta is divided into thoracic and abdominal sections. The abdominal aorta supplies blood into the intestines, abdominal organs, kidneys, lumbar regions, pelvis, and legs. See the branches of the artery. So what is an abdominal aortic aneurysm? And AAA is a focal dilation 50% greater than the normal abdominal aortic diameter of 2 centigrams, and is by definition is greater than 3 centimeters in diameter. Usually there are 4 classifications of the AAA: suprarenal, pararenal, juxtarenal, and infrarenal. So what is the criteria for the endovascular AAA repairment? The AAA diameter exceeding 5.5 centimeter. Symptomatic patients who has evidence of embolization or rupture. Elective repair in women with AAA between 5 and 5.4 centimeter is recommended. When anatomically flexible, EVAR is recommended over open repair for AAA. So the approach to endovascular AAA repairment: bilateral incision. The procedure: the physician will make a small incision in each groin site to visualize the femoral arteries in each leg. Then a stent graft will be inserted through the femoral artery and advanced up into the aorta to the side of the aneurysm. Once in place, the stent graft will be expanded, attaching to the wall of the aorta. The aneurysm will eventually shrink down onto the stent graft. There are also some techniques used for complex AAA. Fenestrated stent graft. The fenestrated stent grafts are commonly customer-made. There is a delay of 4 to 6 weeks in obtaining the graft, thus prohibiting using in urgent situations. Chimney snorkeling configuration. The chimney or snorkeling configuration uses an anti-grade approach to facilitate placement of a covered stent into one or more branches vessels in a parallel course outside the main aortic stent graft. Iliac branch endoprosthesis is another complex segment of EVAR, maybe inadequate distal landing zone and involvements of the iliac arteries. Often one or both of the iliac arteries are extending the stent graft into the external iliac artery. The risk of this technique includes sign claudication, ischemia clotitis, spinal cord injury, ED, and perennial necrosis. The iliac branch endoprosthesis can be used to minimize these complications. So before the procedure, first nursing assessment, assess for comorbidity conditions and risk factors for atherosclerosis, obtain a list of current medication, obtain baseline vital signs, and AAA diagnostic studies, AAA duplex, CT angiography, MR angiography, and angiography. Also, we test the ABI, ankle bronchial index. Also, diagnostic laboratory testing verify that ordered procedural laboratory test has been performed. Notify the physician of any abnormal results. Next, anesthesia evaluation. Maybe use general or local anesthesia. Next part is patient preparation or education. Tell the patient to remove any jewelries, clip any hairs on the patient, cleanse the patient, and establish perineal IV line. Maintain the NPO status. Prevention of contrast-induced nephropathy. Usually will administer IV hydration, use normal saline or 50% dextrose for high risk of contrast-induced nephropathy patients. Manage of antithrombotic medication. Last, prevention of adverse contrast media hypersensitivity reactions. Usually, we administer glucocorticoids and antihistamine medication for patient who is allergic to the contrast media. This shows the checklist before the procedure. Peri-procedural nursing care. During the procedure, before the patient entered OR, first verify the correct patient identifier used to identifiers. Next, assure that the patient has signed the procedural consent and anesthesia consent. During the procedure, monitor BP and ECG rhythm. Maintain core body temperature at or above 36 degrees. Assist with setup and insertion of an arterial line. Insert a urinary catheter. Conduct a procedural timeout before the procedure. Monitor for intra-procedural complications. Last, confirm pedal pulses. Let's see, monitor for intra-procedural complications. If it's possible, it can convert to an open AAA repairment. Vascular access bleeding, hematoma, thromboembolism may be occur, and endoleak, particular type 1 endoleak, respiratory depression. This is the checklist for peri-nursing care list. Last part, post-procedure nursing care. First assessment, we will obtain the vital signs, including BP, apical pulse, respiration, and for the pain and sedative level assessment, cardiac monitoring, administer oxygen via nasal cannula, maintain the IV site and the continuous ECG monitoring throughout the hospital stay. A thorough lower extremity pulse examination or ABI. VTE prophylaxis measures. Maintain head of the bed below 45 degrees to prevent flexation at a graft site. Monitoring urine output. For the incision site care, keep the incision site dry for the first, Keep the incision site dry for the first 48 hours, then remove any dressing. Assess for the complications. First, the endoleak. Endoleak is described as incomplete exclusion of the aneurysm sac by the graft. The classification of endoleak. Usually there are 5 types of endoleak. Type 1, leak at graft attachment site. Type 2, aneurysm sac feeding via branch vessels. Type 2 is the most common, usually accounting for 80% of the case. Sorry, I can't open the video. I don't know why. Type 3, leak through defects in graft. Type 4, leak through graft fabric as a result of graft porosity, often intraoperate and resolve with anticoagulants. Type 5, continue expanding of aneurysm sac without demonstrate leak on image. And another complication is infection. Signs for infection should be monitored, including red in insertion site, fever, abnormal laboratory values, abnormal tenderness, drainage, and pain. Next one, general anesthesia-related complications. If the procedure is performed under general anesthesia, the primary focus is on airway and breathing assessment. Next one, intestinal ischemia. The patient may have abdominal pain, tenderness, diarrhea, nausea, and vomiting. Next one, lower extremity ischemia or acute limb ischemia. Risk factors for this is small or tutored iliac artery and significant thrombus located within the abdominal aneurysm sac. We should pay attention to the 6 P's: pain, pulselessness, paresthesia, pallor, poikilosemia, and paralysis. Next one is aortic fistula. Aortic aneurysm fistula usually occurs later. Most commonly involves to the duodenum, but can be any part of the large or small intestines. Signs including upper GI bleeding and hemorrhagic bleeding. Next one, post-implantation syndrome. Post-implantation syndrome include symptoms of fever, usually more than 100.4 degrees Fahrenheit, and lasting for more than 1 day, and leukocytosis, and also elevated level of inflammatory markers. Next complication, spinal cord ischemia. We should assess for neuromotor defects, check the lower extremity mobility and the quality of bladder control. Last but not least, acute kidney injury. Acute kidney injury is most likely due to application of a suprarenal balloon occlusion or proximal collapse during surgery, heavy contrast, dehydration, or hypotension. Next one, diabetic patient management. For diabetes mellitus patients, we should maintain the glucose between 140 and 180. Usually after EVA, the metformin can be restarted after 48 hours. Patient positioning and activity level. We should provide VTE prophylaxis, maintain bed resting for 4 to 8 hours after cell removal, and give manual compression. If an open cut-down approach is used for graft development, the bed resting time is depending on the physician preparation. Post-procedural medication. Most oral medication can be resumed several hours after EVA once oral intake is tolerated. We should also provide adequate relief of pain after the procedure. Pay attention to these medications: smoking cessation medication, dyslipidemia medication, antiplatelet therapy, and hypertensive medication. Nutrition and elimination. Requirements are dependent on whether AAA are ruptured or not. For non-ruptured AAA, start as chips, monitoring intake and output every 8 hours. Discontinue the urinary catheter no more than the second post-operative day. And for the ruptured AAA, clarify with the physician when to start the diet. Monitor intake and output at least initially every 8 hours. Maintain patency of the urinary catheter. Discontinue the urinary catheter once risk for abdominal compartment syndrome resolves. Post-procedural patient education. Continue prescribed medications, activities, and incision care against lifting any heavier than 10 pounds for 48 hours after discharge. Signs and symptoms to report to the physician. Management of the modelable risk factors, smoking cessation counseling, glycemic control, hypertension management, and cholesterol reduction. Provide antibiotic prophylaxis. And this checklist shows what we should do after the procedure. That's all for my talking. Thank you.
Jen, for sharing your expertise about abdominal aortic aneurysm management. For our participants, you may now input your questions on our chat box.
Hi, Ms. Chen. Thank you for the excellent lecture that you have given to us. It's so enlightening on the part of our nurses. Okay, you projected the proper nursing care of patients with aortic aneurysm from the pre-operative into the post-operative care. I just want to ask you the timeline between the immediate post-operative care and the long-term post-operative care, meaning up to what time we render the immediate post-operative care and up to what time we start and the long-term post-operative care?
Okay, it's a very good question. So, usually, the patient will stay in the hospital for, in my hospital, usually for 5 days. And during these 5 days, we give them post-operative care directly. And after discharge, the patient go home. We will also follow the patient because the patient maybe do some laboratory and CT scans once 2 or 3 months after the procedure. And during the procedure, after that examinations, maybe some of the patients have long-term complications like endoleak. And after find these complications, usually the doctors will give them another operation. So I think it's long-term nursing care. So my speak is just not that long.
Okay. Do you have an institution in China that is exclusively catering cost of care to patients who have undergone vascular surgery, like those who have your aortic aneurysm?
Yes, for the abdominal aneurysm repair, usually there's some like also there's an institution, and there also before the procedure, the patient can choose to join the laboratory. They can choose different graft. There is one kind of graft. Maybe the patient can use less money, and after some time, there is an institution they can supply the graft, and after the operation, maybe one month, 6 months, and a year, the patient will come back to our hospital and do some tests.
Okay, thank you very much. Our nurses, do you have nurses that are trained to take care of people post-vascular surgery? These are specialty nurses?
Yeah, there's nurses, but how to say, there's some of the nurses, they are working in the operating room, and some of the nurses just working in the department of the vascular surgery.
Okay. Okay, that's all, Ms. Chen. Thank you very much for your good answer. Thank you, Adelson.
Thank you, sir.
Thank you, Dr. Alsatin. Thank you also, Ms. Si Chen. Now we will proceed for the awarding of our e-certificates for you. So this certificate of appreciation is hereby granted to Ms. Si Chen for sharing her outstanding knowledge and valuable expertise in the webinar entitled Optimizing Nursing Care Through the Use of Clinical Pathway and Proper Management of Abdominal Aortic Aneurysm Patient. Given this 10th day of June 2022 at the Philippine Women's University, Manila, Philippines, via Zoom and Facebook Live. Signed by Ms. Maria Diana Santos, our event chairperson, Dr. Agaton Manuel Gerard Alzate, our course advisor, and our beloved Dr. Minerva de Ala, Dean of the School of Nursing.
Thank you, sir.
Thank you, Ms. Chen.
Thank you, Ms. Chen. Hope you will be again a part of our webinar in the future.
Okay, thank you, doctor. Thank you, sir. It's my pleasure.
Thank you very much. Stay safe.
Thank you.
It has been a successful event and productive day, don't you think, guys? And to officially close our webinar, let us hear from one of our co-webinar facilitators, Ms. Shana Hu, for her closing remarks.
A pleasant day to all. This is Sona Hu. We have reached the end of this webinar. Attendance gained updates in nursing education and adopt practical strategies that can be used in nursing clinical pathway and nursing management of AA patients. Clinical pathways are guidelines for care of patients and improve high-quality nursing service, reduce cost, interdisciplinary collaboration, and many benefits. Also, we learned about knowledge of vascular nursing and vascular repair of abdomen, aortic aneurysm. It mentions that identifying patients, assessment, and monitoring patients before and after operations, signs of complications, nutrition and elimination requirements, patient education. Today, we are very fortunate to have our respected discussants share their first-rate expertise and experience. Today's speaker is very helpful with our work to update knowledge. Thanks to our speakers, Dr. Joseph Rogondola and Mrs. C. Chen, who have given us excellent talks. I hope that the participants have learned a lot from this webinar. And we are able to convey its signal message to our future success. Respected speakers, attendance in Philippines and abroad, my co-facilitators, our beloved Professor Agato Manuel Azet, the Dean, the whole PW, thank you. I would like to take this opportunity to thank all of you for your almost and heartwarming support to make this webinar event possible. Again, I am Xiaona Hu, one of the facilitators of the very informative webinar entitled Optimizing Nursing Care Through the Use of Clinical Pathway and the Proper Management of AA Patients. I believe that even though we only had a limited time to tackle a lot of interesting things with regards to our topic, we still got the most of it. I would like to send my gratitude to everyone again, closing my remark and officially announcing the end of this webinar. By wishing you all to be healthy, especially at this time of the pandemic. Thank you.
Thank you, Ms. Xiaona Hu. Okay, before we formally end this webinar, we would like to request our dear participants to kindly accomplish the evaluation form by the link that will be provided in the chat box. Failure to accomplish the evaluation form will prohibit you from having an e-certificate for the event. Expect your e-certificates in your personal emails at least a week after this event. And on behalf of our team, thank you all and have a great day. Stay safe, everyone.